Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now, let's get started. Today, we're going to dive into the scientific publication with the title Ultrasound Analysis of the Most Important Musculoskeletal Issues by Dan Chance and Paolo Lombardo. Introduction. Ultrasound has established itself as a diagnostic imaging technique in medicine over the last few decades and has undergone continuous further development. This form of imaging is particularly valued due to the negligible health risk for patients, but also for its rapid availability, cost effectiveness, and the possibility of viewing the tissue in vivo in terms of dynamic examination or using Doppler flow visualization, for example. The use of musculoskeletal ultrasound has risen sharply. A study from the USA showed that between 2000 and 2009, the use of musculoskeletal ultrasound increased by 316% overall, and in private practices by as much as 717%. Due to the various advantages, the question arises as to whether similar growth would be desirable and cost-effective in Switzerland. Compared to magnetic resonance imaging in particular, ultrasound may offer an alternative that is sufficient in many cases, and in some cases even superior, more rapidly available and cheaper. The aim of this paper is to explain the technique of musculoskeletal ultrasound to the reader using the wrist, elbow, shoulder, hip, knee, and foot regions as examples. It is also intended to serve as a guide for practical everyday support. In each case, the positioning of the patient, the correct positioning of the ultrasound probe, and the structures to be visualized are discussed. Several patient cases are presented as examples for each region. To make it easier to understand the steps described, the left extremity is always shown in images and sonographically. The examination steps and images can be transferred to the right side in mirrored form. The choice of colors is taken from the Incellspital's current color scheme. For reasons of readability and clarity, the masculine form is used in this document. However, all people are always meant in the same way. Background. Physical basics. The formation of ultrasound images is based on the reflection of sound waves in the human body. A transducer generates sound waves in the range of several megahertz via voltage changes on piezoelectric crystals. The sound waves are transmitted to the body via ultrasound gel, penetrate the tissue, and are reflected in parts. The different tissues in the human body have different properties with regard to the speed of sound propagation, and therefore also differences in their impedance. As the average speed in different body tissues does not differ massively, most devices calculate the depth of an echo with an average speed of 1540 meter per second, without major distortions of the depth calculation being to be expected. The signals obtained in this way from several coplanar pulses are combined and processed to create an image. An ultrasound probe therefore acts as a loudspeaker and as a microphone as well. Echoes received earlier are displayed close to the transducer, while later received echoes are displayed further away from the transducer on the screen. Musculoskeletal ultrasound. Strengths, limitations, area of application. Strengths. Musculoskeletal ultrasound as a diagnostic imaging technique has many strengths. Nowadays, almost every hospital has at least one device, which is often equipped with a suitable linear probe. In contrast to the frequently prescribed MRI examination, no clarification for body implants is required here, which means that practically every patient is suitable for this type of imaging. Many patients are also unable to undergo an MRI examination because they suffer from claustrophobia. The development of open permanent magnet MRI systems has brought significant relief here. But a study conducted in 2007 showed that 8.3% of examinations still had to be canceled due to claustrophobia. Another study analyzed patient satisfaction after an MRI versus an ultrasound examination for shoulder pain. All patients would have been willing to repeat the ultrasound examination. 10 patients would have refused a second MRI examination. 93 patients preferred ultrasound, 8 preferred MRI, and 17 patients reported no preference. Another advantage is the higher resolution. A 10 megahertz probe has an axial resolution of around 150 micrometers. With an MRI with a field strength of 1.5 Tesla, a field of view of 12 times 6 centimeters, a matrix of 256 times 256 pixels, and a slice thickness of 0.5 centimeter, a pixel, size of 469 micrometers can be achieved. In addition, a dynamic examination of the tissue is possible, which enables, for example, the diagnosis of subacromial impingement dislocation of the ulnar nerve or subluxation of peroneal tendons. There is great anatomical variance in the musculoskeletal system. It is therefore helpful to examine both sides in order to decide whether an abnormality is present or not. For example, the thickness of tendons can vary depending on their habitus, which can make it difficult to establish reference values and thus to decide whether a tendon is thickened or not. In contrast to MRI, it is easy to also examine the contralateral side during ultrasound examinations and thus obtain a comparative image. Although the sonographic visualization of bone is limited, excellent reproduction of the anatomical details of the cortical surface of superficial bone is possible. The high resolution enables the detection and assessment of small changes, some of which are not visible in a conventional X-ray image, such as fractures of the scaphoid or Hill-Sachs lesions. For some examinations, musculoskeletal ultrasound has been shown to be equivalent to or better than MRI. Acute injuries of the lateral meniscus, Achilles tendon injuries, peripheral nerve injuries, chronic lateral epicondylitis, limitations. Despite the many strengths of musculoskeletal ultrasound, there are some relevant limitations. X-ray and computed tomography have a much better representation of bone mineralization and spatial representation of fractures. MRI is superior to ultrasound in the imaging of bone marrow, bone tumors, joints, and muscles that are not accessible to high-frequency ultrasound probes. Ultrasound generates artifacts that do not occur in this way with other examination methods. The quality of the examination is highly dependent on the examiner, as it requires a great deal of expertise and background knowledge as well as practice. Due to large impedance jumps, the sound waves are completely reflected. This means that underlying structures cannot be visualized. A lower transmission frequency must also be selected to visualize deep structures, which reduces the image resolution. Reasons for a standardized examination technique. Ultrasound is considered to be examiner dependent, as the probe can be positioned in any arbitrary position, rotation, angulation, and tilt on the patient. The question therefore arises as to how reliable the assessment and interpretation of a finding is, and whether a different examiner would make the same diagnosis. In order to enable comparable results and clearly interpretable findings, it is necessary to define standard section levels in order to reliably record the relevant and frequent pathologies and to document them in a way that is comprehensible to other specialists. Musculoskeletal ultrasound in general. Performance of a musculoskeletal ultrasound. Musculoskeletal ultrasound refers to the sonographic examination of tendons, muscles, nerves, soft tissue, and bone surfaces. To carry out an ultrasound examination, an ultrasound device equipped with a suitable probe is required. In the musculoskeletal range, A linear probe, usually in the 5 to 13 megahertz range, is generally used. For deeper structures or in obese patients, it may be advisable to use a lower frequency convex probe to achieve the necessary depth. Ultrasound gel is applied to the structure to be examined, which transmits the sound waves from the probe to the target tissue. Gel pads can also be used to minimize artifacts. The region is palpated to localize anatomical landmarks. It is important that the examiner has a detailed and precise understanding of the local anatomy in order to achieve optimal positioning of the probe. The ultrasound probe is placed perpendicular to the surface, with the probe indicator pointing cranially or to the right from the patient's perspective. This allows a standardized visualization of the organs to be achieved. Normally, the structures to be analyzed are shown in longitudinal and transverse axes, with the longest extension of the structure serving as the reference in each case. If the organ lies in a body axis, this is used to describe the positioning. For example, a sagittal section is used for the longitudinal section of the tendon of the biceps capitulum, as this corresponds to the longitudinal section of the tendon. If this is not the case, the terms longitudinal section and transverse section are used. The examined region is displayed on the screen in real time and can be assessed by the examiner. Images and video recordings are normally saved and can be viewed again at a later date or sent as an attachment to a report. Most important artifacts. As with all imaging procedures, the image shown on the monitor does not always reflect reality. There are so-called artifacts that need to be recognized. The artifacts most frequently encountered in the musculoskeletal area are described below. Anisotropy. An isotropy is one of the most common and therefore probably the most important artifact of musculoskeletal ultrasound. It describes the change in the displayed echogenicity of normal tissue when the sonication angle deviates from 90 degrees. This effect is most pronounced in parallel fibered structures such as tendons, less so in muscles, nerves, or ligaments. A common location where this artifact occurs is when examining the supraspinatus tendon, as it has a curved course over the humeral head. A supposed reduction in echogenicity due to anisotropy should not be confused with an injury or even rupture of the tendon. To differentiate between artifact and pathology, the probe is tilted in place until the sound waves strike the tendon at a right angle. At this point, the image normalizes if the tendon is intact. As an example, the iliopsoas tendon is shown here at two different sonication angles. Acoustic shadow. In most cases, only part of the sound energy is reflected during impedance discontinuities. However, in the case of large impedance jumps, such as bone or air, almost all of the sound energy is reflected, which appears as an echo line. The sound shadow artifact can be observed in the corticalis sound head, an image strip of greatly reduced echogenicity. As an example, a sagittal section of the Achilles tendon insertion. In Figure 3, the echo line of the calcaneus can be seen. Anterior to it, the acoustic shadow. In contrast, there is no tissue proximally that would cause total reflection of sound. This makes it possible to visualize deeper structures, such as the Kager fat body. Reverberations. The calculation of the visual representation of the echoes assumes that the sound waves return directly from their reflection to the transducer. However, if several relevant impedance differences occur, reflected sound waves can be reflected again deeper into the tissue on their way back. At depth, they are reflected back again and finally reach the transducer. The increased propagation time allows the echo to be evaluated at a supposedly greater penetration depth. This can also happen several times. In this way, this can result in several incorrectly drawn lines, such as here under the greater tuberosity of the humerus. Systematic targeted investigations. Shoulder. Examination of the shoulder requires flexible positioning of the patient. A rotating chair is suitable for this, whereby the patient can be rotated slightly if necessary. Biceps tendon. The examination of the shoulder begins with the biceps tendon. To do this, the patient should slightly internally rotate the arm to be examined. Flex the elbow joint 90 degrees and hold the forearm in a supinated position. The long biceps tendon can be found most easily between the lesser and greater tuberosities. It should be visualized and documented in its transverse and longitudinal axis. Subscapularis tendon. To visualize the subscapularis tendon, the elbow joint is rotated outwards from the previous examination position. It is important to ensure that the elbow remains close to the patient's body, as otherwise the rotation is compensated for by extension of the elbow, which makes standardized imaging impossible. Supination is also maintained here. The probe is placed in the transverse plane in the position shown. The insertion of the subscapularis muscle can now be viewed at the level of the lesser tuberosity. A large part of this tendon can be visualized by slight passive internal and external rotation, and by moving the probe proximally and distally. The tendon is visualized in cross-section by rotating the probe through 90 degrees. Supraspinatus tendon. To visualize the supraspinatus muscle, the back of the hand is placed on the opposite side of the back to achieve maximum internal rotation, with the elbow remaining in 90 degrees flexion. It is important that the elbow is brought as close as possible to the thoracic wall. In this way, the fibers of the supraspinatus tendon are stretched, and a possible tear becomes more visible. At the same time, internal rotation shifts the tendon insertion anteriorly, making it easier to visualize. The easiest way to find the supraspinatus tendon is to first visualize the biceps tendon in the shoulder joint. A transverse section rotated clockwise by approximately 30 degrees is used for this. As soon as the biceps tendon can be seen, it must be visualized in its longest extension, for which the transducer is rotated. If the biceps tendon is visible in its longest extension, the transducer can be moved cranially while maintaining the rotation. This ensures that the supraspinatus tendon is visualized in its longest axis. If the supraspinatus tendon is displayed, any anisotropy artifacts can be avoided by angulation. By rotating the probe by 90 degrees, the tendon can be visualized in cross-section and be examined in its course. Infraspinatus tendon. To visualize the infraspinatus tendon, the patient is asked to place the hand of the limb to be examined on the opposite shoulder. This ensures better exposure of the tendon. The probe is placed dorsally in the presumed longitudinal axis of the infraspinatus muscle. It is advisable to use the spina scapulae as a landmark and to move the probe caudally from there under visualization until the infraspinatus tendon can be seen in the image. Note: if desired, the tendon of the teres minor can be visualized here by moving the probe further caudally. Acromyoclavicular joint. The acromyoclavicular joint can be examined in the coronal plane by positioning the transducer as shown. It is moved anteriorly and posteriorly to exclude or confirm the presence of an acromial bone. A possible joint effusion can also be visualized here. Patient case 1. Rupture of the long biceps tendon. A 40-year-old patient presented. When lifting a heavy object, he heard a snap in his left shoulder, causing the left biceps to bulge distally. The clinical presentation was a Popeye arm. The subsequent ultrasound examination showed a complete rupture of the long biceps tendon, which could be demonstrated directly and indirectly. The rotator cuff was intact. A subpectoral biceps tenodesis was performed for treatment. Patient case 2. Subdeltoid lipoma. A 65-year-old man presented with a long-standing mass in his right shoulder. No pain was reported. The clinical examination suggested a lipoma. The subsequent ultrasound examination showed a sharply defined lesion measuring approximately 70 times 60 times 35 millimeters between the humerus and deltoid muscle, which was isoechogenic to the surrounding fatty tissue. No calcifications, cystic changes, or hypervascularization could be detected. The mass could be compressed. The axillary nerve and the accompanying artery were displaced by the lesion. The rotator cuff was intact. The ultrasound examination indicated a subdeltoid lipoma with no suspicious signs of liposarcoma. Surgical excision followed. The suspected diagnosis was confirmed. Patient case 3. Tear of the supraspinatus tendon. A 60-year-old woman presented with pain and abduction weakness in her right shoulder. The symptoms had been present for 6 months. Sonography revealed a fluid-filled defect of approximately 15 millimeters around the insertion of the right supraspinatus tendon. The subacromial subdeltoid bursa showed an accumulation of fluid. The rest of the rotator cuff and the opposite side were intact. The radiological findings suggest a complete rupture of the supraspinatus tendon. Elbow. Anterior articular surface. The standardized examination of the elbow is carried out with the elbow joint extended and in the supination position. For patient comfort and to enable full extension, a suitable cushion can be placed under the elbow. Start with the anterior joint surface first. The probe is positioned medially sagittal. By moving the probe laterally, the humeral capitulum is visualized. Distal to this is the anterior fat pad, which fills the coronoid fossa. In a healthy joint, some fluid may be visible between the fat pad and the humerus. The distal humeral epiphysis can be seen in the transverse section, covered by a layer of cartilage, which appears undulating here. The humeral capitellum is located laterally and the trochlea medially. Extensor tendon. To examine the extensor tendon, the elbow is flexed 90 degrees and the forearm is placed on the table in pronation. The probe is placed in the coronal plane, with the proximal end of the probe resting on the lateral epicondyle. In the example shown here for the left arm, the extensor tendon runs from the right in the image along the green arrows to the left. It is advisable to also make cross-sections of the tendon. The lateral ulnar collateral ligament cannot normally be delineated. Radiocapitellar joint. The radiocapitellar joint can be examined in the same position, although a better image can be achieved if the probe is moved slightly laterally and rotated a few degrees anti-clockwise. The radial head can be dynamically examined by passive pro and supination, whereby occult fractures can be visualized. The annular ligament should also be examined. The annular recess is only visible if it is dilated with fluid. Flexor tendon or medial collateral ligament. To examine the flexor tendon, the patient must lean their upper body towards the side to be examined. The elbow is held almost extended and the forearm in forced supination. The probe is placed with the cranial side on the medial epicondyle. In this way, a longitudinal section of the flexor tendon is generated, which is thicker and shorter than the extensor tendon. Posterior to the flexor tendon, the anterior part of the medial collateral ligament is visible. Note: if a partial rupture of the medial collateral ligament is suspected, the arm can be examined in an extended position under valgus stress. In the case of partial tears, the joint space can be widened under load, but not in a healthy joint. Triceps tendon. To examine the triceps tendon, the elbow is flexed 90 degrees with the palm of the hand resting on the examination table. The probe is positioned in the longitudinal axis directly proximal to the olecranon in order to assess the insertion of the triceps tendon. Particular attention must be paid to the distal part of the triceps tendon in order to rule out enthesitis. The posterior olecranon recess is located anterior to the tendon. A suspected joint effusion can be visualized or excluded here by examining the joint at 45 degrees flexion. This shifts any small effusion from the anterior part of the joint to the posterior. Slight shaking movements of the elbow can help to move the fluid. It is particularly important not to apply great pressure to the probe so as not to push away any effusions. Patient case 4. Triceps tendon rupture. A 35-year-old man presented after sustaining an elbow injury while weightlifting. X-rays taken in 2 planes showed no evidence of fresh osseous lesions. In the subsequent ultrasound examination, the triceps tendon on the symptomatic side was found to be 18 millimeters retracted and coiled. Narrow anechoic rim around the tendon is most likely consistent with a resulting hematoma. The opposite side showed normal echo structure and anatomy of the triceps tendon. The findings are in favor of a high-grade triceps tendon rupture and avulsion. Patient case 5. Bilateral anconeus epitrochlearis muscle. A 30-year-old male presented with right shoulder pain with stiffness in the elbow over the last few months. The subsequent ultrasound examination revealed an additional structure superficial to the ulnar nerve, which continued from the medial epicondyle to the ulnar olecranon process and showed a muscular echo pattern. Flexion in the elbow resulted in compression of the ulnar nerve between the superficial accessory muscle and the deeper ulnar collateral ligament. The additional muscle could be visualized on both sides. It is the anconeus epitrochlearis muscle on both sides, an accessory muscle of the medial elbow. The differential diagnosis excluded edema of the ulnar nerve and carpal tunnel syndrome. Patient case 6. Medial elbow snapping. A 15-year-old girl presented with numbness and tingling in the 4th and 5th fingers on the right. The symptoms had been present for the last few days. She was not aware of any trauma. Sonography revealed a normal position in extension and slight edema of the ulnar nerve. Under 90 degrees flexion in the elbow joint, the ulnar nerve dislocated anterior to the medial epicondyle. Under complete flexion, the caput medial of the triceps also dislocated. Under extension, the muscle dislocated first, followed by the nerve. Compartment 1. The examination of the wrist begins with the examination of compartment 1. To do this, the patient is asked to hold the forearm in a neutral position. The probe is placed transversely on the radial styloid. The tendons of the abductor pollicis longus and the extensor pollicis brevis can be examined here. Particular attention should be paid to the question of whether the retinaculum is intact and whether there is a vertical septum. Possible additional tendons can be detected in the distal course of the tendons. Compartment 2. To examine compartment 2, the forearm is brought into a pronated position so that the palm of the hand rests on the examination table. The probe is moved ulnarly from the previous position in order to visualize the second compartment, which contains the tendons of the extensor carpi radialis brevis and longus muscles. If the probe is moved proximally, the crossing of the tendons of the first compartment can be visualized. Compartments 3, 4, and 5. The patient positioning from before is maintained. The probe is moved further ulnarly to examine compartments 3, 4, and 5. To differentiate between the tendons in compartment 4 and to recognize the extensor digiti minimi, it may be helpful to ask the patient to flex or extend individual fingers. A low echo rim can be seen dorsally of the ulna, which is caused by the articular cartilage of the ulnar capitulum. It should not be confused with effusion. Compartment 6. To examine compartment 6, the forearm is positioned in an over-rotated pronated position with the radius side in contact with the table surface. The probe is placed on the ulna directly proximal to the transverse ulnar styloid process in order to examine the tendon of the extensor carpi ulnaris muscle. Radiocarpal and midcarpal joints. To examine the radiocarpal and midcarpal joints, The forearm is returned to the pronated position so that the palm rests on the table. The ultrasound probe is positioned longitudinally. The synovial recess of the radiocarpal and midcarpal joints can be examined in this way. Particular attention should be paid to effusion or synovial thickening. Dorsally, the extensor tendons run longitudinally in the image. Carpal tunnel. To examine the carpal tunnel, the forearm is placed in a supinated position so that the back of the hand touches the table surface. The probe is placed transversely at the level of the proximal carpal tunnel so that the scaphoid tubercle is visible on the radial side and the pisiform bone on the ulnar side. Slight tilting can help to visualize the soft structures. In particular, the flexor retinaculum should be checked, as well as all 9 long flexor tendons. If there is a clinical suspicion of a tendon lesion, the integrity can be checked in the longitudinal axis with passive movement. Attention should also be paid to any muscle malformations or tendinosynovitis. The tendon of the flexor carpi radialis muscle should be checked on the radial side. Patient case 7. Flexor pollicis longus. A 20-year-old male presented for a sonographic examination. 1 month previously, he had sustained a cut to his right wrist. Clinical findings included a loss of flexion in interphalangeal joint I and reduced sensitivity in the radial fingers. Sonography revealed a laceration of the flexor pollicis longus muscle, which widened to approximately 25 millimeters when flexion was attempted, suggesting that it had been completely severed. The median nerve also showed a laceration of approximately 5 millimeters. Both findings could explain the patient's symptoms. The diagnosis was confirmed intraoperatively. Patient case 8. Carpal tunnel syndrome. A 70-year-old man was referred for an ultrasound examination with suspected left carpal tunnel syndrome. Sonography revealed edema of the median nerve directly proximal to the left carpal tunnel. The diameter of the nerve was approximately 14 millimeters. The nerve was compressed in the carpal tunnel. No mass was seen in the tunnel, nor was there a bifid median nerve or persistent median artery. Patient case 9. Ganglion of the scaphotrapezial joint. A 20-year-old woman presented with a palmar radial lump of the left wrist. She reported moderate pain over the last few months. Sonography revealed a well-defined, lobulated, thin-walled, anechoic avascular lesion in the region of the scaphotrapezial joint. A small incomplete septum was recognizable, as well as a dorsal sound enhancement. The pedicle process of the lesion extended to the scaphotrapezial joint. The nearby tendon of the flexor carpi radialis muscle was normal. The case shows a volar ganglion of the wrist, originating from the scaphotrapezial joint. A ganglion is the most common mass lesion in the hand and wrist. Anterior joint surface or iliopsoas tendon. To examine the hip, the patient is placed in the supine position. To assess the iliopsoas tendon and anterior joint capsule, the probe is positioned in the sagittal plane at the level of the femoral head. The glenoid appears here proximal to the joint capsule as a hyperechoic triangle, similar to the structure of the meniscus of the knee. Additionally, the iliofemoral ligament can be assessed in this position as well if desired. In obese patients, it can be helpful to switch to a convex probe with a lower frequency in order to adequately visualize the deep-seated structures. Muscle tensor fasciae lati and muscle sartorius. To examine the origins of the muscle tensor fascia lata and sartorius, the probe is positioned in the transverse plane at the level of the anterior superior iliac spine. The image shows the short tendon origins, lateral and medial, of the hyperechogenic line of the anterior superior iliac spine. The muscles can be visualized and traced in longitudinal section by rotating them through 90 degrees. The tensor fasciae lati muscle is shown here, which can be traced by moving it caudally to the insertion on the iliotibial tract. Adductor muscles. To examine the medial hip, the hip is abducted and externally rotated, and the knee is flexed. The probe is placed on the protruding adductors in the longitudinal axis of the leg. The protruding os pubis can be used as a landmark for the proximal end of the probe. 3 muscle layers can be seen, from superficial to deep. 1. Adductor longus. 2. Adductor brevis. 3. Adductor magnus. Muscle gluteus minimus or medius. Fascia lata. To examine the lateral hip, the patient is asked to lie on the contralateral side. The probe is placed in the coronal section at the level of the greater trochanter and moved slightly proximally so that it is at the distal edge of the image. The distal part of the gluteus minimus muscle and its insertion can be examined here, as can the tendon of the tensor fasciolati muscle and the transition into the iliotibial tract. In cross-section, the greater trochanter is also visible as an echoic line in depth. The insertion of the gluteus minimus muscle is located anteriorly. By moving it posteriorly, the gluteus maximus muscle can be examined first and the gluteus medius muscle further posteriorly. In a healthy patient, the bursae around the greater trochanter are not visible. Hamstrings. To examine the posterior aspects of the hip, the patient is placed in the prone position. The probe is positioned sagittally in order to locate the ischial tuberosity. Directly proximal to this, the common tendinous origin of the following muscles can be visualized: muscle semimembranosus, semitendinosus, and biceps femoris, caput longum. The individual tendons cannot usually be differentiated using the examination technique shown here. Hernia. The patient is placed in the supine position to clarify whether an inguinal hernia is present. The probe is placed transversely over the lateral edge of the rectus abdominis muscle. Under Doppler control, the inferior epigastric artery, which originates from the external iliac artery, can be visualized by moving the probe infralaterally. The probe is rotated clockwise by approximately 70 degrees in order to visualize the inguinal canal and cross-section. The entire length can be searched for a hernia by transverse displacement. Rotation by 90 degrees anti-clockwise also visualizes the longitudinal section. A direct inguinal hernia passes through the medial inguinal fossa and exits through the superficial inguinal annulus. An indirect inguinal hernia, on the other hand, penetrates through the profundus inguinalis annulus, runs in the inguinal canal, and exits through the superficial inguinalis annulus. In both cases, a passage can be provoked by increasing the pressure in the abdominal cavity. Case study of an indirect inguinal hernia. Male patient. Figure 91 shows a longitudinal section of the hernia consisting of peritoneal fatty tissue and intestine. Figure 92 shows a transverse section of the hernia. Case study of the Valsalva maneuver for indirect inguinal hernia. The sex of this patient is unknown. A Valsalva compression test revealed a hernia sac in the inguinal canal running along it. This suggests an indirect inguinal hernia. Case study of a direct inguinal hernia. Shown here is a case of a direct inguinal hernia. The contents of the hernia are pushed forward to the right edge of the image under Valsalva pressure. The reference to the inferior epigastric artery is helpful for orientation. The sex of this patient is unknown. Patient case 10. Avulsion of the muscle adductor longus. A 60-year-old man presented after a fall to the ground that led to a severe abduction of his right hip. The accident had happened 2 weeks before his visit to the doctor. He complained of slight pain in his right groin. An X-ray showed no evidence of an acute osseous lesion. The subsequent ultrasound examination revealed a fluid-filled defect replacing the insertion site of the adductor longus tendon. The tendon shows a retraction of 15 millimeters. The myotendinous junction of the adductor longus is normal. In the adjacent pectineus muscle, there are some tiny fluid clefts with small areas showing a normal muscle echo pattern. The muscle adductor brevis, adductor magnus, and gracilis show a normal echo pattern. The contralateral adductor muscles were examined in comparison and were normal. This case shows a complete rupture of the adductor longus tendon at its origin. In contrast to this case, adductor injuries are usually sports-related. Patient case 11. Septic arthritis of the hip. A 7-year-old boy presented with pain in his left hip. The pain had occurred 2 days ago during a martial arts lesson and had not changed since then. The physical examination revealed severe pain in the left hip. The patient was unable to walk. Laboratory tests revealed an elevated level of C-reactive protein. A bilateral hip ultrasound was performed. Sonography revealed an effusion in the anterior recess of the left hip joint up to 5.4 millimeters. There was no hypervascularity of the neighboring tissue. Intact femoral cortex. Normal right hip joint. A child with severe hip pain, elevated CRP, and hip joint effusion is highly suspicious of septic arthritis. During surgery, pus was found in the left hip joint. Staphylococcus aureus was isolated from blood and hip joint effusion cultures. The absence of hypervascularity on power Doppler examination does not rule out septic arthritis. Patient case 12. Tear of the acetabular labrum. A child with severe hip pain, elevated CRP, and hip joint effusion is highly suspicious of septic arthritis. During surgery, pus was found in the left hip joint. Staphylococcus aureus was isolated from blood and hip joint effusion cultures. The absence of hypervascularity on power Doppler examination does not rule out septic arthritis. Labral tears are a common finding in hip arthroscopy for hip pain. A tear of the acetabular labrum can be asymptomatic, but can also cause groin pain. Over time, labral tears can cause permanent hip damage. The current gold standard of treatment is hip arthroscopy, with labral tears being the main indication. Conservative therapies are also available. Knee. Quadriceps tendon. To examine the quadriceps tendon, the patient is positioned in a lying or sitting position with approximately 30 degrees flexion in the knee joint. A cushion can be placed under the knee joint for this purpose. The probe is placed sagitally directly proximal to the patella. The hyperechogenic line of the patella should be visible at the distal edge of the image. Directly anterior to the femur is the prefemoral fat pad, recognizable as a larger hyperechogenic mass. A second fat pad is located proximal to the patella. In between lies the suprapatellar synovial recess, which is slender and slightly S-shaped in healthy patients. Larger pathological effusions can be detected here even at rest. Isometric contraction of the quadriceps by the patient or compression of the parapatellar recess with the examiner's free hand can also detect smaller joint effusions, as the fluid escapes cranially. A distinction can be made between synovial thickening and a questionable effusion by applying pressure to the probe. If the finding is displaceable, it is an effusion. Otherwise, it is synovial thickening. The probe should also be moved medially and laterally so as not to miss smaller effusions. Trochlea femoralis. To examine the trochlea, the knee is fully flexed. The probe is placed transversely above the patella. The cartilage and the quadriceps tendon can be assessed here. Patellar tendon. To examine the patellar tendon, the patient is again positioned with the knee in 30 degrees flexion. The probe is placed on the apex patellaris and then rotated around this fixed point until the entire length of the patellar tendon is visible. The tendon can be assessed in this way, as can the Hoffa's fat body, which lies posterior to the tendon. Caution. The origin of the patellar tendon forms a V shape around the apex. This region should also be examined so as not to miss any tendinopathy. A slight enlargement of the infrapatellar bursa profunda is physiological and can be visualized as a small triangular hypoechogenic area. The superficial infrapatellar bursa cannot normally be visualized. Medial collateral ligament. To examine the medial aspects of the knee, the leg is externally rotated while maintaining a flexion of 30 degrees. The probe is positioned in the expected longitudinal axis of the medial collateral ligament. It is often necessary to move the probe distally and proximally for a full-length examination, as the tendon is usually longer than the ultrasound probe. Valgus stress can be helpful in assessing a suspected ligament lesion. The outer part of the medial meniscus can also be viewed here. The lateral collateral ligament. To examine the lateral collateral ligament, the leg is internally rotated while maintaining 30 degrees flexion. The probe is then placed in the longitudinal axis of the expected ligament extension. For correct positioning, the fibular head can be used as a distal reference point. Then the probe is rotated around this fixed point until the ligament is visible in its greatest length in the image. The outer portion of the meniscus can also be seen here. If a meniscus cyst is suspected, the examination can be repeated with the knee in forced flexion, as the fluid is pressed laterally. In the area of the tibiofibular joint, joint effusions and periarticular ganglia can be searched for. Intercondylar fossa. To examine the popliteal nerve vessel bundle, the patient is asked to lie in the prone position. The probe is placed in the transverse direction at the level of the knee bend. By moving it proximally and distally, the popliteal artery can be visualized in depth, the popliteal vein in the middle, and the posterior tibial nerve. If the popliteal vein cannot be seen, the knee can be slightly flexed, which fills the vein and makes it easier to visualize. Patient case 13. Quadriceps tendon rupture. A 50-year-old man presented 4 months after trauma to the anterior distal third of the left thigh. He had a non-MRI compatible prosthetic heart valve. There was a complete rupture of the quadriceps tendon. Retraction from the patella. The defect showed a small amount of anechoic fluid and a prolapse of the subcutaneous fatty tissue. Patient case 14. Tendosynovial giant cell tumor. A 20-year-old female presented with anterior swelling of the left knee for the past few months. She reported mild localized pain. The ultrasound examination showed a well-defined lesion in the area of the swelling, measuring approximately 19 times 16 times 13 millimeters. The lesion was located in the subcutaneous plane. It was separate from the joint and located medial to the patellar tendon. The lesion was hypoechogenic, slightly heterogeneous, and showed no calcification or cystic changes. There was posterior acoustic enhancement. It showed slight compressibility. There were a few flow signals in the peripheral part of the lesion. The quadriceps and patellar tendons were normal. There was no effusion in the suprapatellar region. The lesion was surgically excised. Histopathology revealed a tendosynovial giant cell tumor. Patient case 15. Infrapatellar bursitis. A 25-year-old woman presented with pain in her left anterior knee that had been present for 2 days. There had been no trauma. No X-ray was performed as the patient was 8 weeks pregnant. The ultrasound examination showed an anechoic fluid accumulation at the site of pain reported by the patient. The fluid was located at the site of the deep infrapatellar bursa. The patellar tendon, Hoffa's fat pad, and quadriceps tendon were normal. There was no effusion in the suprapatellar recess of the knee joint. Ultrasound revealed an infrapatellar bursitis, which explained the symptoms satisfactorily. Ankle. To examine the ankle joints, The patient is asked to sit on the examination table and flex the knee 45 degrees so that the sole of the foot can be placed on the table. Anterior ankle joint surface. To examine the anterior ankle joint, the probe is positioned in the sagittal plane in the direction of the second beam. By moving the probe medially and laterally, fluid can be searched for in the anterior recess of the tibio-talar joint. Ligament talofibulaire anterius. To examine the anterior talofibular ligament, the foot is slightly inverted to stretch the lateral ligaments. The probe is placed parallel to the examination table, with the proximal end resting on the lateral malleolus. Anterior tibiofibular ligament. To examine the anterior tibiofibular ligament, the probe can be rotated cranially from the position described above while maintaining the anchor point on the lateral malleolus until the entire length of the anterior tibiofibular ligament can be viewed. Peroneal tendons. To examine the peroneal tendons, the probe is placed directly posterior to the lateral malleolus so that the malleolus is still cut at the anterior edge of the image. The tendons are examined by moving the probe parallel to their course. Deltoid ligament. To examine the posterior part of the deltoid ligament, the foot is tilted laterally by rotating outwards in the hip while maintaining flexion in the knee until the lateral edge of the foot comes to rest on the examination table. In addition, the foot must be dorsiflexed as far as possible. The probe is placed slightly distal to the medial malleolus in a slightly rotated coronal plane so that the proximal end lies over the malleolus and the distal end of the probe is moved anteriorly or posteriorly until the ligament can be visualized in its longitudinal axis. Achilles tendon. To visualize the Achilles tendon, the patient is asked to lie in a prone position. The foot should protrude over the table so that the OSG can be freely flexed or extended. The probe is then placed in the sagittal plane from the dorsal side so that the distal end of the probe comes to rest over the calcaneus. In this view, the insertion of the Achilles tendon and the anterior proximal Kager fat body can be visualized. The length of the Achilles tendon is then traced up to the myotendinous junction and checked for signs of rupture. Plantar fascia. To examine the plantar fascia, the patient can be left in the same position. The probe is placed in the sagittal axis plantar above the heel just medial to the midline so that the calcaneus, recognizable as a convex line with a rich echo, appears on the right edge of the image. Patient case 16. Rupture of the anterior talofibular ligament. A 20-year-old female presented a few hours after an inversion injury to her right foot. She complained of difficulty walking and lateral pain and swelling of the affected ankle. An X-ray did not reveal a fresh osseous lesion, but showed a discrete widening of the lateral joint space. Sonography revealed a complete rupture of the anterior talofibular ligament near the fibular insertion. The rest of the ligament showed a normal echo pattern. The anterior recess of the ankle showed an effusion and lateral subcutaneous edema. Patient case 17. Achilles tendon rupture. A 40-year-old male presented following trauma to his left Achilles tendon. The patient complained of pain in the area of the Achilles tendon. The ultrasound examination showed a complete tear of the Achilles tendon. The tear was located 60 millimeters proximal to the tendon insertion. There was a gap of 25 millimeters between the two edges of the torn tendon. The defect was filled with fluid, with the echo pattern indicating hemorrhage. The tendon proximal and distal to the tear showed a normal echo pattern. There was a tiny enthesophyte at the insertion. The asymptomatic tendon was intact and showed a normal echo pattern. Patient case 18. Longitudinal tear of the peroneus brevis muscle. A 35-year-old male presented 2 months after injuring his left ankle. He complained of pain in the area of the lateral ankle and an occasional cracking sound. Ultrasound examination revealed a longitudinal transection of the peroneus brevis tendon in the area of the retromalleolar groove and just distal to the lateral malleolus. The length of the tear was approximately 35 millimeters. No tenosynovitis was visible. The proximal muscle belly and the distal tendon insertion were normal. The peroneus longus tendon and muscle belly were normal. No injury to the peroneal retinaculum was visible. No subluxation or luxation of the brevis or longus tendon in relation to the retromalleolar groove. The calcaneofibular ligament was normal. This case shows a split tear of the tendon of the peroneus brevis muscle. The presence of 3 structures in the retromalleolar groove could be an indication of an additional peroneal muscle, however. This is unlikely in the context of the symptoms. Patient case 19. Instability of the peroneal tendons. This case shows a retromalleolar intra-articular peroneal tendon subluxation in a young skier that was not recognizable on MRI and could be detected on a dynamic ultrasound examination. A transverse section at the level of the lateral malleolus with the ankle joint in neutral position shows the tendons of the peroneus longus and the peroneus brevis in anatomical position. The arrow points to a slightly thickened superior retinaculum. B. During active eversion of the ankle, the tendons abruptly change their position in the retromalleolar groove. Note the increasing laxity of the superior retinaculum. C. When the ankle joint is in the neutral position, the tendons change abruptly again into their anatomical position. Discussion and conclusion. This work shows the most important standard sections of relevant questions in musculoskeletal ultrasound of the wrist, elbow, shoulder, hip, knee, and ankle. Exemplary images with descriptions of the sections and anatomical structures were created and the positioning of the patient explained. Several patient cases per region were also presented and explained in order to place the described procedures in a clinical context. The advantages and disadvantages of the imaging procedures were explained and compared. Musculoskeletal ultrasound is particularly strong in the visualization of superficial structures, whereby this form of imaging is superior to other imaging procedures in some cases. In addition, the detection of inflammation, for example, is not only possible via indirect signs compared to computer tomography. In addition, the hyperperfusion caused by inflammation can be visualized directly at the affected site using Doppler examination. Even in the case of functional restrictions, such as shoulder impingement or tendon instability, which are difficult to visualize using other imaging techniques, the tissue can be viewed and moved in vivo using a dynamic examination. This can lead to a better understanding of the pathology and a more precise diagnosis. Musculoskeletal sonography therefore proves to be a valuable addition to everyday clinical practice. The focus of the work was the presentation of common standard ultrasound incisions in the musculoskeletal area. The intention to keep this guide clear and to cover the common pathologies is limited by the fact that not all sections could be covered. In a future work, further, less frequently used incisions could be shown in order to cover a broader spectrum of possible pathologies. For example, sections of the thorax could also be shown. A further question is whether musculoskeletal ultrasound can save or replace an MRI or CT examination in certain cases. As discussed in the introduction, this would be an advantage from the patient's point of view and in economic terms. Further studies investigating this aspect would be valuable. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.